Okay, good afternoon, everyone. We're thrilled to see such a great turnout for the first Health Outcome Seminar for 2017. As many of you know, the Health Outcome Seminar Series is sponsored by the Center for Pharmacoepidemiology and Economic Research, also by the CCTS Beach Program. Today is our pleasure to have Dr. Sharmilee Nyenhuis as a presenter. Dr. Nyenhuis received her bachelor's in science from Milken University and her medical degree from the University of Illinois at Chicago. She completed an internal medicine residency also at UIC and an allergy immunology fellowship at the University of Wisconsin in Madison. Currently, she is assistant professor in the section of pulmonary critical care and sleep medicine at Allergy here at UIC. And she also serves as the director of the Allergy and Asthma Clinic here at UIC. Her research focuses on disparities in asthma among older adults and minority populations. And today she will be speaking to us about some recently funded research that focuses on addressing physical activity among African American women with asthma. Please help me welcome Dr. Nyenhuis.
Well, thank you, Edith, for inviting me to speak today. And again, thank you for everyone's interest in coming to my talk today. So I have nothing to disclose, and really the objectives of the talk today are to review some of the disparities in asthma morbidity and mortality and physical activity among African American women with asthma, as well as understand some of the barriers to engaging in physical activity that are unique to asthma, and then also discussing an intervention that is aims to increase physical activity among minority populations with asthma. So briefly, I know not everyone is as familiar with asthma, so just wanted to briefly point out that asthma and its impact. It's a chronic disease of the airway and causes airway inflammation among the airway that can cause episodes of wheezing, breathlessness, chest tightness, and nighttime or early morning coughing. And these symptoms can be triggered by a whole host of things, including allergens in the environment, like pollens, dust, mold, pet dander, as well as exercise itself can trigger these symptoms, as well as other things like cold air, strong odors. So about 25 million Americans have asthma, and that's about 1 in 13 people have asthma. And the prevalence of asthma has been increasing. And the cost of asthma to the U.S. are over $56 billion per year, and that includes days missed from work, and also due to the mortality of the disease as well. So as I mentioned, the asthma prevalence is increasing and is actually higher in women as well as in African Americans. This data is from the CDC, and as I mentioned here, women have a greater prevalence of asthma as well as African Americans as far as looking at race. So as I mentioned, asthma in African American women. So actually African American women carry some of the highest burdens of asthma. So they have more emergency department visits, more hospitalizations, and they also, especially older African American women with asthma, they have a higher rate of mortality compared to other races and ethnicities. So as you can see here, again from the CDC, where that African Americans have greater emergency departments, hospitalizations, and death. So what are some of the reasons for, again, these greater hospital visits, emergency room visits, greater symptoms, and death due to asthma among African American women? So there's many reasons. There's not just one. And I know some of the people in the audience are community health workers, and they actually know this firsthand, that, pests, so rodents, cockroaches, mold in the home, smoking. Other things include depression, sedentary lifestyle, stress, obesity, hormones. So there's a lot of reasons. There's not just one that are contributing to the reasons why the greater hospitalizations and poor asthma control among African American women with asthma. So additionally, African American women are fewer than 15% of African American women actually meet the physical activity guidelines, and this is one of the lowest of the adult subgroups. And there's many reasons for this, and some of them, and I'm going to go into a bit more detail of this, is social and culturally based differences, as well as community environment influence, including safety and community support, and a lack of community role models. So, as I mentioned, African American women have some of the lowest levels of physical activity, but there's also unique barriers that African American women face. So in 2015, there was a systematic review that looked at different barriers to physical activity among African American women with asthma, or just African American women. So there are about 42 studies that were included in that, and they actually divided the barriers into 3 different levels of influence. So they saw that there are intrapersonal, interpersonal, and community and environmental barriers that actually influenced the ability to engage in physical activity. So using this socioecologic framework to actually classify some of these barriers, they looked at, as I mentioned, the interpersonal. This ended up including attitudes, beliefs, knowledge, and personal traits, as well as the interpersonal is more the interaction between social groups and other cultural influences, and that includes interacting with friends, family, peers, and other cultural norms, and then also looking at the community environment and some of those characteristics that can influence physical activity, including physical neighborhood and community structures, characteristics, as well as weather. So to kind of list out some of the barriers that the systematic review kind of found that were in African American women, and the ones that I have bolded are the ones that were more specific to African American women, because as you can see, some of these we all face in trying to engage in physical activity, like limited time, lack of motivation, lack of knowledge, tiredness, other health conditions like fatigue, muscle soreness, and injury. But some of the things included physical appearances like hair care maintenance, cost and time. So that's something that they found that African American women, it costs a lot for hair care for some African American women, and if you have to be washing your hair after you're exercising every single day, then that could be an added cost. As well as the time to do hair. Also body shape preferences. So in one of the studies in the systematic review, they found that the body shape preference, more so in African American women, was a more curvaceous body shape. Other things as far as the interpersonal components included the role of family and gender. So often this study found that African American women are often the primary caretaker, and so they have a lot of things to manage, and that takes precedence over themselves. And also I found one thing that was really interesting is that they thought that physical activity is a self-indulgence, and you're kind of being selfish on taking care of yourself and exercising, and putting that above some of the other caregiver or caretaker duties. Also, a lack of social support was another barrier related to physical activity specific for African American women. Now, looking at some of the cultural and environmental components, so one of them was no role models for physical activity. So another one is also safety concerns for neighborhoods. So they can include a lot of different things. So gun violence and gangs, physical harm. They had written in one of the papers, they had written that people were throwing things at a person that was walking or exercising outdoors. So that was a concern. It's just if the neighborhood's known to be unsafe after dark, and then also stray dogs. So that's another thing that is a safety concern, as well as a lack of sidewalks or poorly maintained sidewalks. I'll talk a little bit more about some of the work I've been doing as far as focus groups, but that's definitely something that I ran into a couple days ago when I was doing a focus group that that was a really important issue, is that in their neighborhood they don't have sidewalks, or if they do have sidewalks, they're very not level, and they were concerned that maybe they would actually hurt themselves if they were on the sidewalks, if they tripped and fell. Also, another thing are lack of facilities in the neighborhood to exercise, and then something that unfortunately we have to deal with here in Chicago is either it's too hot or it's too cold to do physical activity. But again, that's not necessarily as specific to African American women. So I kind of reviewed some of the barriers to, again, physical activity among African American women. Now, kind of my focus is looking at asthma and how that is a barrier to physical activity. So there have been studies showing that, number one, asthma patients engage in less physical activity than age-matched controls without asthma. And as you can see here from this study, that they looked at measures of physical activity. So they looked at being inactive or vigorous, and these are self-reported, that if they currently had asthma, they were more inactive than those that never had asthma, as well as they engaged in vigorous activity less so than those that never had asthma. In addition, there have been studies too showing that these low levels of physical activity in asthmatics, also those patients had poor asthma control, poor asthma-related quality of life. They had more asthma exacerbations, and they also used healthcare services like emergency departments, hospitalizations, more so than those that had engaged in either regularly active or in vigorously active physical activity. So with that, this came some of my my interests as far as looking at, okay, well, what about, what are some of the barriers to physical activity in asthma? So some of the things are from previous papers that have shown is that many patients actually avoid physical activity because they think they're going to trigger asthma symptoms. As you may remember on my very first slide, I said that one of the triggers of asthma besides allergens is exercise itself. So this is a very valid point that exercise or physical activity can trigger asthma symptoms, as well as but there have been studies looking at exercise in asthma. Mainly the studies that have been done at a, typically kind of like bringing patients to UIC at an academic center or having them come to a gym. And when they have done that, they have found that physical activity is actually very safe in asthma, especially when some guidance is given as far as, what to do when you start having asthma symptoms, or there's also ways to actually use asthma medication prior to exercise to help prevent the asthma symptoms from coming on. So in addition to the physical activity being safe in asthma, exercise actually has been shown to reduce inflammation in the lungs of asthmatics, as well as improve asthma symptom-free days, so meaning they have more days where they're not having symptoms, as well as reduce asthma exacerbations. So this study, this was done by Boyd and colleagues. They showed here, this was before and after exercise. So this is in a set of controlled patients that had asthma that didn't receive the physical activity intervention versus receiving the physical activity intervention. And this FeNO is actually a measure of airway inflammation in the lungs. And the airway inflammation then, as I stated earlier, can cause all those asthma symptoms. So this showed that after exercise, after being in training for a 12-week program, that their inflammation actually did decrease. And then also, again, as I mentioned, looking at their symptom-free days, this is they found in the training group at 30, 60, and 90 days that they all had increases in the number of symptom-free days. So again, exercise, while it may be a perceived barrier for many asthmatics to engage in, is that actually exercise can help improve asthma symptoms, as well as reduce exacerbations and reduce the inflammation that occurs in the airway. And based on all this work, the guidelines actually recommend asthma patients to engage in low to moderate exercise at least 2 times per week. So this is something that is in the guidelines itself. So what about physical activity in African American women with asthma? And this is a black hole. So there's really no work in physical activity in African American women with asthma. So as I stated, there's no published data that is actually looking at the physical activity levels in this population. And so this is something where, again, my interest lies, but we can kind of extrapolate from the fact that, number one, African American women have lower levels of physical activity, and asthmatics have lower levels of physical activity than non-asthmatics, that they likely have low levels of physical activity in general. So we started off with this, trying to look a little bit at the physical activity levels of African American women with asthma. And we did this here at UIC in my clinic. And we conducted a survey in 41 African American women, and we also did some key interviews with 10 African American women with asthma. And some of the things that we found is, first, the frequency. So looking at the national guidelines of exercising or engaging in physical activity more than 5 days per week, less than 40% or about a third of patients were actually engaging in physical activity. Now, this is self-reported, and there's a lot of data showing that self-reported data, people overestimate their physical activity levels. So often if people say they're doing about, exercising 5 times a week, they are probably doing a little bit less than that. So the next, one of the other things we asked them is, after finding out how frequently they were engaging in physical activity, is what are the types of physical activity they actually want to participate in, or which ones they currently participate in. And as you can see, walking was really the preferred physical activity. And some of the other ones included dancing, aerobics, bicycling, swimming, and some people just said they aren't participating in any. So the next question, we did this with asking in some of the interviews, the key interviews that we did with some of our patients, is we asked them, well, where do you walk when you do walk? So a lot of these patients do walk in their neighborhoods, parks, and gyms. And then some of them do, again, this is a small sample, but some of them do walk indoors, outdoors in the summer, in the work, and less so within the home, backyard, or mall area. So again, getting to finding out how asthma is a barrier, or what are some of their barriers to physical activity in this population. A large majority of them did find that asthma was a barrier. So they were fearful that they were going to have an asthma attack if they engaged in physical activity. Another surprising thing is that pain was another big thing. So I guess surprising or not surprising, but a lot of other comorbid conditions, such as arthritis, fibromyalgia, those can definitely present as a barrier to physical activity. And then other things looking at access, companionship, and safety were other noted barriers. So then we asked patients too, okay, are you interested in increasing your physical activity levels? And sorry, this didn't come out, but 88% of the patients did want to increase their physical activity levels, compared to 12%. So it is something that they're interested in doing, and they enjoy walking, it seems, the most so, and walking around their neighborhood or in parks. And but they do have this fear of an asthma attack, which appears to be a barrier to engaging in physical activity. So again, coming back to the slide, what are some of the reasons for this increase in morbidity and mortality among African American women? One way that we can consider to address this is through walking, and walking in the neighborhoods, something that is community-based. So as I mentioned, there is actually a lot of research that actually really supports the development of tailored physical activity interventions, especially in African American women, because they've been shown to be more successful than those that are developed for other race groups. So, and as I showed earlier, there are multiple different barriers that African American women particularly tend to experience that limit physical activity. Also, additionally, community-based interventions that really account for caretaking needs, work roles, they also have been shown to kind of help facilitate shown to facilitate adherence to physical activity in African American women. So these are two important things, kind of, again, tailoring it to African American women as well as having it community-based as well. So my hypothesis was by increasing physical activity through a community-based walking intervention will actually help improve asthma outcomes in sedentary African American women with asthma. So as I mentioned, asthma, and sometimes it can be induced by exercise that can cause shortness of breath, leading to physical inactivity, as well as that can also lead to something called deconditioning, where that can, if you don't exercise very much, then you start feeling short of breath even climbing a flight of stairs. So that leads to more physical inactivity. So my intervention would act at the physical inactivity and, again, hope to decrease asthma control and improve asthma quality of life. So through 3 aims, I'm trying to address this. So this is for a career development award that I received this summer through the NHLBI. And first of all, it's really to engage African American women with asthma to identify barriers to physical activity. Again, I did show you a little bit of work that some preliminary work that we had done in a small population here at UIC, but we do want to, again, I get more feedback to help try to identify those barriers. And then actually modify a validated community-based walking intervention guided by this stakeholder input. And then thirdly is kind of assessing, is this feasible? Is it acceptable for the women that are engaging in, for these women? And then kind of use the data that we also obtained from this pilot study is to actually then later on at another stage is to actually test to see if it actually does improve asthma control and asthma quality of life. So just kind of taking a step back, looking at, are there walking interventions tailored for African American women that are out there already? So there are a lot of interventions to increase walking in general, but really very few are tailored to African American women and are community or home-based. So of those that are community and home-based and actually tailored for a lot of the barriers that African American women experience in regards to physical activity, there's these 3. There's Zollner, which is Fit for Life, Banks-Wallace, and Forthover, and these all, again, as I said, developed tailored interventions for African American women. Now, I know this is a little small, but all of these occurred in middle of Missouri, the Mississippi Delta, and the middle of South Carolina. So all of those, again, all of those studies were really targeting rural African American women. So as far as looking at here, since we're in Chicago, which is a metropolitan area, there's really only one that has actually has been specifically tailored for African American women and has been in an urban setting. And luckily, that was actually here in Chicago. So Joelle Wilbur, she actually used to be here at UIC. She was in the College of Nursing, and she's actually at the UIC North Campus, I hear, which is Rush. So she's there, and she's done this women's walking program. And what the Women's Walking Program is, as I stated, it's a culturally sensitive, community-based walking intervention for sedentary African American women. And this has been guided by different theories. One being the social cognitive theory, which addresses problem solving, goal setting, self-monitoring, role modeling, supportive feedback, as well as looking at the client-professional interaction component, which looks at health information, decisional control, and social support. And it really has been designed to help kind of move women from kind of thinking about like, oh, I know I should exercise and I know that's going to be good for me, but to actually starting to prepare. Okay, what are the things I need to do to actually kind of move and get walking into those actionable stages of motivational readiness. So some of the framework looking of the women's walking program, again, is looking at some of what are some of the determinants to adherence of physical activity, and those are definitely some demographic, environmental, social support's a big one, as well as current health status. So other health problems, menopausal status as well. And then they looked at how this impacted the interpersonal kind of domain, which includes self-efficacy and outcome expectations. So meaning like, what do they expect to come out of this physical activity? So this intervention looked at doing group visits and individual telephone strategies to do an adoption phase where they did 5 in-person group sessions, and then they did a maintenance over a 2-year period, and then they did a maintenance phase where then they kind of did, less frequent, but then they were looking at, again, how adherent the participants were with this intervention. And then the outcomes that they were looking at, again, is looking at mainly adherence, but they also looked at fitness, body composition, and depressive symptoms as well. So again, this, as I mentioned, it was designed by and really for African American women, and they used a lot of formative work and stakeholder feedback to help kind of design this. And as I mentioned, it was very community-based, so it occurred within different community-based clinics. And again, they gave them a tailored walking prescription, and then they had group discussions that really addressed the goals and barriers and kind of used, again, social cognitive theory, the components of the social cognitive theory to kind of address self-monitoring, self-efficacy. So the women's walking program has shown to improve fitness among African American women, and it's increased physical activity. Also, they did find adherence with it, and they did use an automated phone physical activity tracker, which also helped improve adherence. And how that was is pretty much women had a pedometer, and they would call this automated phone tracker, and they would enter in their steps for the week, and then based on if they met their goals or not, it would provide either inspirational messages regarding, or motivational messages that would help kind of keep them engaged and hopefully improve adherence, and which it showed that it was effective with that. So the next stage of Dr. Wilbur's work has been actually modifying the women's walking program into the women's lifestyle physical activity program. And this is a combination now of community-based group meetings to discuss, again, these goals and barriers, this walking prescription, as well as looking at physical activity adherence. And during the intervention, again, it does say that there is no increase in BMI or body composition, but in a way that's actually a good thing, because often people do gain weight over time, and so this actually helps stabilize their BMI and body composition. Obviously, people. The goal of this was not to lose weight; it was to increase physical activity and physical fitness. So with that, again, the women's walking program, while it has been, shown to be have some efficacy, they actually did exclude patients with chronic lung diseases. So there's not a lot of data out there in patients that have, in a walking program, in patients that have chronic lung diseases. So again, kind of my proposal is to kind of look at how asthma, like one of the current health issues, can actually be kind of plugged into this framework, and then again look at asthma health outcomes like asthma control, quality of life, maybe even consider looking at inflammation. As I showed earlier, some of the other data has shown exercise reduces airway inflammation and exacerbations. So as I mentioned, my first aim is to kind of use stakeholder input to kind of to help us validate the walking intervention itself, or to modify this walking intervention, the women's walking program. So our plan right now is to conduct focus groups in 30 women with asthma to begin to assess these physical activity barriers in facilitators. And I'm kind of going to go a little bit through some of the framework that I'm using to actually kind of look at this refinement. So one of the things I'm using, it's called the Behavior Change Wheel framework, and it's actually designed to incorporate existing theories of behavior change, but it really is based on looking at this model. It's called the COMBI model of capability, opportunity, and motivation that all impacts behavior. So looking at capability, looking at the physical capabilities of the patient, of the women, also the psychological capabilities, as well as opportunities. So do they have social opportunities? And also the physical opportunities. We talked about that earlier as far as if they have a gym or a safe place to walk. And then motivation, so looking at their reflective motivation and automatic motivation. And then this model then it can be incorporated into a full range of different interventions, looking at an education intervention or persuasion, training, multiple different ones, enablement interventions, and then these are all likely to be, that can be potentially effective in eliciting behavior change. So again, applying it to what I'm looking at, as I mentioned, we're looking at the capability, which is really kind of focusing on the psychological capability. So looking at the awareness of what are the physical activity recommendations for African American women with asthma, looking at skills of asthma self-monitoring. So do they know how to monitor their asthma symptoms? Do they know what asthma symptoms are? And then also looking at attention to places to walk. So maybe some of the sidewalks are bad or in this neighborhood, but maybe they forgot, hey, there's a park district a few blocks away from me, and there are walking paths in there. And then also looking at the motivation. So again, looking at beliefs of physical, what are the beliefs of the benefits of engaging in physical activity? What are the consequences? And I think obviously that's one thing, especially specific to asthma, since there is this fear of inducing asthma symptoms with exercise. And then also their capability to engage in physical activity. And then the opportunity, as I mentioned, the physical environmental resources, and then also the social opportunity. So what are the social influences of friends and family? And again, part of that can be social influences of, as I mentioned earlier, being the primary caretaker and not having time to actually take the opportunity to engage in the behavior. And obviously, again, the desired behavior is to increase physical activity or walking among African American women with asthma. So as I mentioned, kind of using those components, that's really what guided my interview guide for my focus groups. So I'm asking questions about what's the knowledge about physical activity and asthma in general. Like, is it safe to do it? Is it recommended? Does your doctor recommend it? Also thinking about action planning, as I mentioned earlier. What are the steps that you need to take to start engaging in physical activity or walking? Self-monitoring, as I mentioned, different symptoms, the attention to places, what are the resources in their neighborhood, what's the social support and norms, and do they have self-confidence and perceived competence? And then again, just asking about some of their perceived risks and attitudes to physical activity, engaging in physical activity and asthma. So my hope is once we complete the focus groups, then we'll really be able to kind of link this, these categories, the COMBI categories, to specific intervention functions. And some of the things that I'm thinking that what we'll be doing is again, one barrier being the knowledge about physical activity. That's in regards to the psychological capability. We will, in the intervention itself, will focus on education and training. And again, the attention to places to walk in the community, that'll be education. Some of the cultural expectations of engaging in physical activity, that will be modeling. So we'll use role modeling in the intervention. And then also looking at fear of exacerbation when doing physical activity, that will be more education and modeling. So maybe having other women that have asthma, that have engaged in physical activity, and giving providing their experience about how maybe they were fearful but kind of overcame that fear. So again, using modeling that way. So as far as in my AIM 2, we will be adapting this women's walking program to kind of address all these barriers and facilitators that we found in the focus groups. And we're going to utilize a multidisciplinary team of a kinesiologist and a specialist in exercise-induced asthma, women's health, and a behavioral scientist as well, to all help us kind of figure out what's the best way to kind of modify this intervention. And actually, you know, Dr. Wilbur is involved in this because she's one of my mentors. So she's the women's health specialist. So it's a great opportunity to be able to work with the person that came up with the initial walking intervention. And again, as I mentioned, we're going to kind of address some of these potential modifications, meaning education on physical activity and asthma, and also maybe some of the specific steps to reduce asthma symptoms. And additionally, we will be incorporating some basic asthma education because, again, a lot of the community health workers here know, and actually clinicians as well, is that, you know, there's a wide variety of what people's asthma knowledge is. And then the last thing is that through a unique partnership with the Chicago Park District, we're hoping to utilize them to actually, this is where we're going to have the intervention. So again, that kind of helps address the attention to places to engage in physical activity, as well as it being community-based or, you know, close to their home. So just kind of briefly, these are some of the potential session topics that we're thinking of that will be included. So as I mentioned, there'll be 5 sessions, and we'll be talking about how to increase physical activity, and then setting step goals in patients. Then also looking at session 2, we'll be looking at what are some of the realistic expectations. You can't expect that after the first or second week of walking, you're going to be able to walk 5 miles. And then also handling like outdoor triggers for asthma. So, you know, we're going to have that's going to be an issue, especially in the spring and fall, in patients with asthma, because many of them do have allergies. And then looking at some of the other things that, again, may not be as specific to asthma, looking at time management, but also in there looking at proper technique of a rescue inhaler, because that's something that we often recommend using prior to engaging in exercise for asthmatic patients. And then how to handle a relapse. So, you know, you get sick, you go on vacation, the holidays, those are all relapses, and how to also face disincentives. And then the last session will be kind of really about sharing experiences. So, again, once we modify the intervention, the last aim is that we are planning to test this in 80 women with asthma, and this will be a randomized controlled pilot, and the intervention we've named so far is called ACTION, which is physical activity in minority women with asthma. And again, as I said earlier, we're really looking at the acceptability and feasibility. From this, we're not going to be able to determine is this efficacious or not. So this is kind of briefly the study design, which I mentioned will be collecting some, baseline measures, and this would occur in a healthcare setting here at UI Health, and then also doing an asthma education and physical activity session within the Chicago Park District, and then separating into the intervention over 8 months, as well as a enhanced usual care. One reason why we're doing enhanced usual care instead of usual care is because we know doing nothing really has no improved outcome. So we wanted to at least do a little bit of something by providing some education. So as I mentioned, right now our recruitment, our thoughts for recruitment are really to recruit from our institution here, UI Health, and we're going to identify patients through an electronic health record algorithm, which I have used for some of my other asthma studies, and then also target patients through the patients that we pull from this through mailings and other clinic visits. But we're not completely, since we are still in the planning phases of this, we are still thinking about community-based recruitment as well. And some of the things that kind of, again, we're including African American women between these ages. They have to be sedentary. And then we are actually including women that are not optimally controlled with their asthma. And, these are some of the other things, providing consent as well as being randomized to the different intervention arms. So I'm just going to go ahead and let me kind of just talk about, go ahead and kind of start wrapping up my talk about the intervention. So as far as, again, we're going to be really looking at the feasibility, and we're going to do a feasibility evaluation, and we're planning to do, once the intervention is done, looking and throughout the intervention, using surveys and interview methods to really look at how feasible this is among participants, but also among the interventionists that will be conducting the intervention itself. And then also with we have a park district liaison that we are also using to see. So kind of not just focusing on one thing, but kind of seeing the big picture, how they're really evaluating it, again, so we can expand this. And we do expect this to be feasible and have a high rate of acceptability, but as I said, and then this will help us provide some data so we can in the future inform and perform an efficacy trial. So some of the additional measures that we're also going to be looking at, again, these are all kind of focused on what framework we're using. And so we're going to be looking at asthma knowledge and asthma self-efficacy, looking at some safety measures, because we want to see if a lot of people that are exercising, maybe it isn't safe for them to be doing what they're doing. Also looking at self-efficacy for walking, social support for exercise, and then looking at their outcome expectations and other perceived barriers like safety and other social factors like loneliness and social cohesion. So these are kind of more mediating effects. So just kind of as a start, when this is going to start rolling out, our idea is that we're hoping to start the actual intervention in August of this year, and then it will run for about 2.5 years for us to enroll and complete the intervention. So like I said, we're finishing up our focus groups now and hoping to take some time to modify the intervention, the original women's walking program, and hopefully start in August later this year. So just kind of as a summary, I hope I kind of portrayed these definite kind of bullet points, is that African American women are disproportionately affected by asthma, with lower lung function, quality of life, exacerbations, and mortality rates, which is the most concerning. And African American women are less physically active. This low physical activity has been associated with poor asthma control, lung function, and quality of life, and more exacerbations. And given this connection of African American women with poor asthma outcomes and also physical inactivity, kind of addressing physical activity is something that is really imperative. And interventions need to be community-based also, and incorporate input from the targeted population, be tailored to African American women, and I think also theory-based, is which kind of what I was showing as well, to really help address the high morbidity and mortality rates in African American women with asthma. So I'd just like to thank my mentor, Lisa Sharp, also David Marquez, Joellen Welber, and my multiple advisors, and then my research assistants, and of course the study participants that have already helped in some of the formative work we've collected. So thank you.